Good morning. I'm Anna Marie de la Vega. Thank you for joining us today. This is Focus. Today we're going to talk about women's heart health and some new things that are going on that are going to hopefully make life better and healthier for a lot of women in our community. We are talking with Dr. Nishtha Sareen, the medical director of the Women's Heart Program at Ascension St. Thomas. Welcome. Thank you for joining us.
Thank you, Anna. Thank you for having me.
Now, you say you are an interventional cardiologist?
That's correct.
So what does that mean?
Means a plumber of the heart.
Oh, good.
So I open up clogged arteries and put in stents for a living, and learn a lot about how blockages can present differently in women versus men.
Really?
Yeah, it changes. I mean, the symptoms are different. Women are not going to have chest pain, chest pressure, going to the jaw, going to the arm, going to the back. It's not the Hollywood heart attack we talk about. They maybe just feel dizzy. They might just feel lightheaded. They just might not feel right. So that is why women have to be more aggressive about pursuing care when they feel something's not right.
If I just felt dizzy or lightheaded, I probably would not want to go, let's call an ambulance and spend all of that money and all of that time in the emergency room. I think that might be part of the problem. We are quiet about it, and it's expensive.
Absolutely. And also, we are the caretakers of the family. So we think about everybody else before we think about ourselves. And if I were to feel dizzy, I think the first thing I would think about also is if I'm in the hospital or if I'm at the doctor's appointment, who's going to pick up the daughter? Who's going to take her to her classes? You know, who's going to be there to take care of family at home? So, but we have to learn that a healthy woman in a family can create generations of health. So it's really important to take care of yourself.
I want you to say that again, please, doctor, about a healthy woman.
A healthy woman creates generations of health.
We teach it to our kids. We model it for our children. What should we do to stay healthy? I know a lot of things we kind of know we should do to stay healthy. How do we know if we're already down that road to not being healthy, and can it be turned around?
Those are all great questions. If you look at the data that we have out there, exercise and healthy eating are more likely to benefit women compared to men.
Really?
So if a woman decides to exercise by guidelines, which is 30 minutes, 5 days a week, and it can be in any format. I mean, it has to be 150 minutes a week. You could be 10 minutes, 15 times based upon what works best for you.
Yeah.
But you can do your own mix. So for instance, as a part of the program, we launched Wednesday workout, which is during lunch hour, chair yoga. For 30 minutes for working women, and sitting on the chair, they can burn up to 300 calories. Little interventions like that go a long way.
And you talked about the program that you just launched, the Women's Heart Program at Ascension St. Thomas. Tell us about that. Let's get into that, because you just kind of piqued our interest right there.
Of course. So Ascension St. Thomas has launched the Women's Heart Program, which is one of the most comprehensive programs, not only in the state, but actually in the country.
Oh, wow.
We are going to be taking care of women in all stages of their lives, not only when they are pregnant, but also from the time they are born to the menopause, to every event in their life until the last stages, because we understand that there are conditions that affect women disproportionately compared to men. For instance, there is something called microvascular dysfunction. It's a condition that affects small arteries of the heart, something we don't see on a coronary angiogram. So these will be women who have had chest pain, chest pressure. They've been to the hospital and they've been told, your arteries are fine. It's not coming from your heart. Probably anxiety. And then they end up at mental hospitals, or they see multiple psychiatrists and nothing works. And they keep having chest pain, and ultimately they start to live with that chest pain. Europeans started to test for this before us, but in 2021, it was endorsed by our American guidelines to test women for microvascular disease. And we are one of the centers that does the most comprehensive testing for that. If you have microvascular dysfunction, it increases the risk of stroke, increases the risk of heart attack. It's not something, in fact, even death, it's not something that should be taken lightly.
What does that mean, microvascular disease, the tiny little
arteries in the heart? And frankly, now we know that those little arteries in the heart are not only in the heart, those arteries also supply the brain and the kidney. So when you have microvascular disease, now we are learning that could also potentially increase the risk of dementia and kidney issues in women down the road.
Aren't you excited to go to work every day and go like, what else did we learn today?
Oh, absolutely. And believe me, we learn the most from our patients. They tell you, they teach you something new every day. We had one of our patients who's been in the ER 20 times last year, already 7 times this year with microvascular dysfunction. She just came to our program, and we are hoping that we are able to make a difference in her lives. And what was really striking and what we learned from her was actually from her husband. And he has been the one who's been taking her to the ER 20 times last year. It just goes to tell you how much impact this can have on the entire family.
Did they know for a long time that it was microvascular disease, or did they just find out recently?
They just found out recently. We tested them last week.
They found out last week?
Last week. So now we have her on medical therapy, and hopefully we can keep her out of the hospital.
After all of that heartbreak and that anxiety and expense.
Mm-hmm.
Oh,
Absolutely.
I'm so proud of what you guys are doing. That is amazing. So that is just one of the ways that women are affected disproportionately with heart issues. What other ways can heart disease affect women in a different way than it affects men?
Of course. So when a woman has diabetes, her risk of death or having complications is 7 times higher compared to her peers. But when a man has diabetes, it's only 3 times higher, which means when women develop these conditions, they do worse. So it is not only the conditions that affect them disproportionately, but things we know about like diabetes, hypertension, atrial fibrillation affect women differently. They should be treated differently. And what's very striking in the literature right now is that despite us knowing that heart disease is the number 1 killer of women in the United States, we have failed as a community to provide them evidence-based care, whether it's medications, whether it's interventions. Women just are not provided that care as commonly as our male counterparts.
What does evidence-based care mean?
Evidence-based care means, sorry about the medical jargon,
No.
but it does mean that treatment options that have been delineated after clinical trials and research, which is a complete another discussion because all the trials that have been done historically to study drugs, to study different devices, 85-90% of the participants have been men. Mm-hmm. So we only know what works in men, and we assume that will work in women, and we use it. So it's a complete different paradigm which we are trying to change at our evidence level and at physicians level to get more women to participate in clinical trials.
And then we will have evidence that it works in women.
Absolutely,
Not
yes.
just an assumption that it would because it works in men.
Absolutely, yes.
What have you found so far? Have you found some things so far, like stents and devices that work differently in women?
There was one of the trials that came out with Impella. So when I do plumbing in the heart, a lot of times people are in shock state when they come in with a massive heart attack. And we put in heart pumps. And one of the heart pumps is Impella. And we know from one of the recent trials that it makes a lot of difference in outcomes, that it can decrease the risk of deaths. But women don't have that much benefit from that pump. And one of the thoughts is that women have smaller vessels, and these are large-size pumps. So there's more risk of bleeding in women, which could perhaps change the outcomes.
Yeah.
Also, we have to learn that women are built differently. Their composition is different. The conditions that affect them are different. The risk factors are different. For instance, we often don't talk about eclampsia, preeclampsia during pregnancy. I mean, when we go to our physicians, when have they taken our obstetric history of how many children do we have? Having 3 or more children increases the risk of heart disease by 20%. When have we been asked if we have had hysterectomy or early menopause or our age of menarche? Early menopause increases the risk of heart disease by 25%.
Oh my gosh. What is considered early menopause?
Before 40 years of age.
Wow. And having more children.
Having more children.
Why? Do we know why yet?
That's, again, a great question. Is it because of the stress of pregnancy? Because pregnancy is a stress test. So you are doing that stress test multiple times. Your body's going through all those changes. Or is it that these women are already predisposed? Mm-hmm. And when they have been pregnant so many times, we see the worst outcomes. The jury is still open. The answer is going to be in the trials and programs like these where we see patients, we see them, they're seen by experts who collect the data and are able to contribute to the literature overall.
Did you say pregnancy is a stress test? Is that what you called it?
It's a lifelong stress test, isn't it?
Holy cow. I love that. Well, what other stressors might women be dealing with that affect them differently than from men?
So there's a condition, it's called the broken heart syndrome.
That's real.
It's real. And, the heart muscle starts to look like an octopus holder from Japan. So that's how it gets the name of Takotsubo's cardiomyopathy. It's a broken heart syndrome. Typically happens in women after 40, 45 years of age. And under a massive stress, they will come in with chest pain, EKG changes, angiogram looks fine, but there is heart failure. The heart function decreases to 25-30% from normal 60%. And that affects women disproportionately compared to men. Again, how this happens, we are still learning about it. What is the exact mechanism?
Wow.
And that goes to tell us we've known about this for so many years, and why are there still these gaps?
So this is the medical director of the Women's Heart Program at Ascension St. Thomas. This is a program that was just launched recently.
That is correct.
And it's statewide?
Statewide. We have 3 clinic locations already active. One is at Rutherford, one is at Midtown, and one at Franklin. Patients can just call 615-284-4HER to get an appointment, or online, just Google the website and there's a template, you can fill it in, and one of our coordinators will get hold of you right away.
Now, should we get in touch if we have issues, or we think we have issues, or if we feel like we're healthy, should we get in touch?
So I would say if you have health issues, have shortness of breath, any symptoms, and you want to be ruled out, family history of heart disease, any risk factors like dyslipidemia, hypertension, or you had complicated pregnancies, premature labor, all of those would categorize as patients who would be at higher risk. But also, I would tell you that if you are, once you're postmenopausal, 40, 45 years of age, our risk of heart disease exponentially increases. And it's never a bad idea to get checked and make sure everything is taken care of. For instance, there's one of the initiatives that we launched. One of the beauties of our program is that we have 13 champions who are 13 subspecialists who would be open heart surgeons and advanced heart failure, advanced preventive cardiologists, who work together to provide the best care to our patients who come to our program. And one of the programs we are launching is breast artery calcification.
Is what?
Breast artery calcification.
Okay.
So what is it?
Yes, you saw that in my eyes. Yes.
No, it's, we get mammograms. We've all had mammograms. When have we ever been told whether there was calcium in the breast artery? That is something that the people who are reading it, radiologists, they can see it. It's just about reporting it. And we have data that if a woman has any degree of calcium in that breast artery that can be seen on a routine mammogram, they are at higher risk of stroke, heart attack, and death.
So should I go back and have them reread my mammograms from the past few years?
I would, if you can, have them look at it again. It is in the same study. It's right there, just needs to be reported. And hence, we are launching a program where we are going to ask our radiology colleagues, they are one of our champions, collaborate with them and have them look at those mammograms and report the artery calcification so women who have higher risk are identified early.
When women come in and they have had a stroke, now will that previous information be looked at as well as what's going on now?
So that's such a great question, right? It becomes about prevention versus treatment.
Yeah.
And when you are already treating the episode, you've lost the battle, is how I look at it. You want to prevent that, because when a stroke has happened, going back, and of course we can go and look back. We always go look back and say, oh, could we have caught it 10 years ago? Could we have caught it 20 years ago? And what's heartbreaking is that majority of the times, yes, we could have.
But that will help you learn for other women.
Absolutely true.
Before you're treating it.
Absolutely.
So if a woman has a heart attack or stroke, what kind of outcomes could she expect?
So it depends upon how quickly. So that brings a really important point on. I'm glad you asked this. This is something where we partner with our patients. When you have a stroke or a heart attack, we only have so much time to save that brain and that heart. Time is money. So when there's a heart attack, our team gets activated and we have to get to the hospital within 30 minutes. When we get to the hospital, my job is to open up the artery within 90 minutes from the symptom onset, from the chest pain starting.
Wow.
Because if we do take more than 90 minutes to get blood flow back to that artery, that heart is very less likely to recover.
Whoa.
So knowing your symptoms, understanding that this could be stroke or this could be heart attack is really, really important, and to seek medical attention immediately.
Mm-hmm.
And for that, it's also equally important for every person in the family to understand what the symptoms are.
Mm-hmm.
Because if any family member, whether it's a male or a female, frankly, anybody is having a stroke or a heart attack, you should get medical attention with adequate knowledge right away.
With adequate knowledge, meaning don't try and Dr. Google it yourself.
Know the symptoms, credible symptoms.
Yes.
Have credible evidence. Know that you have reliable source of information and seek medical attention.
Okay, so would you go over some symptoms again for me, please? And before you answer, I want to remind you, if you're just joining us, this is Focus. I'm Anna Marie, and we're talking with Dr. Nishtha Sareen, the medical director of the Women's Heart Program at Ascension St. Thomas. Because you mentioned earlier a couple of symptoms, and you kind of rolled by them, and I'm like, wait, what? And how bad does the symptom need to be for you to go, okay, this I need to go to the emergency room for?
Absolutely. So if you have chest pain, of course, if you have typical chest pain, chest pressure, going to the jaw, going to the arm, going to the back, left arm numbness, pain that radiates up your neck, please seek medical attention right away.
Is it usually in the left side?
It could be either side of the chest. It could be either shoulders. It could go up either side of the jaw or either arms. It doesn't matter.
The jaw.
The jaw.
Why?
Well, it radiates to the jaw because of the nerve innervation in the heart. And what's very interesting is that there are very few pains that go from chest to the jaw, or from chest to the shoulder, or chest to the arm.
Oh.
And heart attack is one of those, especially if that happens when you walk, or you're doing physical activity, or you're stressed, or you're lifting something, or you're going up the stairs or down the stairs. That is a red flag. In women, even shortness of breath on walking, going up and down the stairs, or picking heavy weights, or if you think, I get tired more quickly now and I feel better when I sit down, that demands attention and workup. Now, whether every shortness of breath needs to go to the hospital, probably not, but knowing your numbers is where this becomes important. If you have abnormal lipids, if you have hypertension, your medications for that. If you have family history of diabetes, or you have diabetes, if you have family history of heart attacks, or people died without a known cause, those would be the patients who should have a very low threshold to get medical attention.
And what is the lipids? Is that your cholesterol levels?
Cholesterol levels. There is a good lipid and a bad lipid.
Mm-hmm.
Good lipid is HDL. That is something you're born with. The higher, the better. There is very little we can do to fix it. LDL is the bad lipid. We want it lower. The lower, the better. That's the one that's associated with most bad outcomes.
Mm-hmm.
It's easy to test. It's a blood test. And every person should know their numbers, their LDL and HDL numbers.
What should they be? What is a good range?
LDL should be less than 100, and HDL, the higher the better. Definitely more than 45.
Oh, okay. Okay. Wow. So know your numbers.
Mm-hmm.
You can find out from your doctor.
Mm-hmm.
And if you have the shortness of breath, you said repeatedly, you want, and especially if you have some of those other factors, risk factors in your life, your family, all of that. And you said even an unexplained death?
An unexplained death, because that could be a heart attack. And family history is one of the most important elements in heart disease. I mean, I have known patients who've been hypertensive all their lives and still do fine. And then there are patients who've done fine all their lives. They've been healthy, they've never smoked, and then suddenly they have a heart attack in their early years, in their 40s.
Wow.
And the reason typically lies in the family history.
Okay. Probably we can find that out as well. And you said lightheadedness or dizziness or things like that for women?
Absolutely. There are women who feel dizzy, lightheaded, just don't feel right, feel more tired, more fatigued.
Is this also after exertion?
Could be after exertion. So it starts with being after exertion. That's when it'll start. And believe me, most of the women are not going to come seek medical attention in the beginning.
No.
But over time, it happens with minimal activity and even at rest.
Oh, okay. And say it again, lightheadedness.
Lightheadedness, dizziness, palpitations, fast heart rate, just not feeling right, feeling tired, feeling nauseous, feel like throwing up. All those could be signs of heart attack.
Wow. Okay, so the palpitations, the heart beating fast, is that a heart attack or is that something else?
So if you think of your heart, I like to talk to my patients as to think about it like a room. It's got walls, it's got doors, it's got electricity, it's got plumbing. Heart attack is the plumbing part of the heart, and palpitations is the electrical part of the heart. So it is AFib that you worry about more with palpitations, but there is a connection between plumbing and electricity. So a lot of times when patients are having a plumbing issue or a heart attack, they could also have palpitations. Does that make sense, Anna?
Yes, it does. I have a friend who had strokes. She also had the AFib, and that was before the strokes.
Absolutely.
And would that have been a possible symptom that was a possibility for her in the future, that a stroke would be in the future possibly?
Absolutely, yes. There is atrial fibrillation is a very common reason for strokes, and there is a score that we can calculate. It's called the CHADS VASC score. You can just Google it, put in your values in there, and you can find out whether or not a blood thinner needs to be given to prevent a stroke.
Whoa. Okay, so a woman has a heart attack. What are the various outcomes that we could see?
So that's a great question. When a woman has a heart attack and she recognizes it and she goes to the hospital right away, we have had patients who have lost their pulse or their heart stopped and they recovered and they walked out of the hospital. That's definitely possible as long as we can get to the artery quickly and we fix it and go to a good center. Of course, there are times, especially when women have atypical symptoms. So we have had women who have had nausea and they just feel tired. They weren't sure what was going on. And then suddenly they collapsed and then they were brought to the hospital, which was delayed presentation is what we call it. In that case, there are times when the heart muscle may get damaged and may never come back. There are times when the heart muscle will get damaged. And also, because of no oxygen going to the brain for that much amount of time, you could have anoxic brain injury. And it could be more detrimental outcomes compared to when we talk about quality of life as to becoming wheelchair bound.
Anoxic means that you did not get oxygen to your brain.
That's right.
And so the brain injury would be that it would cause you to be unable to...
It's almost like a massive stroke. So you wouldn't be able to function. You'd be on a wheelchair.
Oh, okay. And what about a stroke?
Same thing with stroke. If you come in time, you get the therapy in time, the outcomes can be beautiful. But if the presentation is late, which typically happens in women, then the outcomes are not great, which means they will have residual deficits. They will have, unable to move their arm or their leg, the part that was affected by the stroke. And of course, it can lead to massive deaths as well.
So what are the symptoms for stroke? Are there precursor symptoms or do you have symptoms when you're actually having a stroke?
So one of the big risk factors for stroke is hypertension. So you have to manage that adequately.
High blood pressure.
High blood pressure.
Yeah.
AFib, like you mentioned, it's a big risk factor. If you have sleep apnea, you're at higher risk of AFib and stroke. So be very mindful that you take any palpitations very, very carefully, very, very seriously.
Yeah.
The symptoms you're looking for is weakness, one side of the face, one side of the upper extremity, arm or leg, or just not speaking right, slurred speech, if there's a vision change. All of those could be signs of stroke.
Does that mean you're actually having one or it is impending?
It is you're having one. If you have any of those symptoms, if you have difficulty speaking, slurred speech, change in vision, weakness, mainly in one side of the body, seek medical attention immediately.
Is there something that we should do on the way if we feel a female family member or us feel like, okay, I feel like I'm having a heart attack. What should I do on the way to the doctor if I'm conscious?
So if you're conscious and you're having a heart attack, you can put in a baby aspirin in your mouth.
Okay.
But even if you do not do anything and get to the hospital in time, they will take care of it right away. We have guidelines that once a heart attack is detected, we have to get certain medications in your system within 10 minutes.
Yeah.
So all of that will be taken care of. But if there's one thing you could do is probably just take a baby aspirin.
What about stroke?
Stroke, I would probably not take a baby aspirin because sometimes stroke can lead to bleeding complications in the brain. So if you think you're having a stroke, the best bet is to get to the closest emergency department.
Just go.
Just go.
I interviewed a woman who had the jaw pain and was having a heart attack and went to her doctor and was kind of shamed away. Like it's you're fine, that kind of thing. And then she ended up having a very, very severe heart attack with injuries, with follow-up damage. Is that one of the things you're trying to help address as well with the Women's Heart Program at Ascension St. Thomas?
That's spot on, Anna. Yes. When we miss diagnoses or, everybody can make mistakes when it comes to, diagnosing patients. But when it happens way too often, it is a problem. And in women, a lot of women, when they complain about chest pain, chest pressure, or jaw pain, which is kind of typical, it's not even shortness of breath, they do get neglected. Fault lies among us because we have historically believed that heart disease is a condition that affects men. It's not a disease of the women. We have done a great job, generating awareness about breast cancer. And I must congratulate my colleagues, but women have to understand that heart disease is a six times bigger killer than breast cancer. Heart disease kills more women than all cancers combined. So you cannot take that lightly. If you think your condition is concerning, I would advocate for it. I would make sure you're heard. Adequate testing is done.
Women tend to lose their voices around male authority figures sometimes. The white coat figure, the white coated figure who tells them it's nothing, just get some rest, that sort of thing. And so I feel like having a women's heart center, women's heart program might help them feel more free to express their concerns.
I would agree, Anna, and a lot of women feel that way as well. Having a dedicated women heart program does two things right away. One, it gives women that comfortable level where they can come and be themselves and voice their concerns. And two, this is a group of physicians who specialize in conditions that affect women disproportionately. We learn about it. We work together to develop new initiatives to address it. So you are likely to get the best care possible at an institution and a center that's dedicated to women's heart health.
I noticed one of the pieces of information on the website said the Women's Heart Program at Ascension St. Thomas, the Women's Heart Center, is working to help make healthcare more affordable and available and accessible to women. How can you do that?
Even if we improve the medical care, the biggest problem is getting it to our patients. And the way we address that is by going to our patients and not every time asking them to come to us.
Really?
So how do we go to our patients? We have multiple sites that we have located. So our Women Heart Program has got 3 clinics that are active, which brings us closer to our patients, makes it more accessible for them. We have on-site dietitian who sees the patient every time and we don't tell our patients, okay, you got hypertension, watch your salt, see you next time. The dietitian will sit with you, work on your menu, give you food options. So we partner with you as you make those lifestyle changes to make it not just accessible, to make what we are doing more impactful for our patients. We have exercise physiologists involved. So patients who say come to our Rutherford clinic, they can get membership at our local gyms who we partner with for $18 a month. So it's interventions like that that will motivate our patients to get up and do what needs to be done. Because it's easy to blame them for not doing it, but we also have to come halfway to provide those resources to our patients. Also, the other way we make it more accessible for them is by doing community outreach. So we go out in the community, we'll do blood pressure checks, we screen women, and hopefully can diagnose a lot of them with the conditions that would not have been diagnosed otherwise. It's fascinating, and also, Anna, it gets scary at times because we have seen patients who come for routine scaring and they're in AFib screening and they're in AFib at the time of their routine EKG, and we are like, oh gosh, okay. And then we calculate the score for them, and the score is so high. Then they get the care that they deserve, and they get on blood thinners, and then a stroke is prevented. And what I also want everybody to understand is that we should learn to appreciate the disasters that we have prevented, not the disasters that we treat. We have to appreciate to learn that, oh, you know what, this is a problem I had, and I could have had a major issue and it did not happen. Anna, there's one thing I want to say is that when we are doing interventions for women's heart, when we are trying to improve it, we need to partner with our male colleagues as well. And, it's Ascension St. Thomas. I do want to acknowledge the fact that our leadership has done a phenomenal job with pushing this, advocating for this, and letting this get a front stage, make it front and central.
Mm-hmm.
So I do want to thank our Fahad Tahir, our CEO, who has taken it on very personally to advocate for this. I want to thank our physician leader, Dr. Evelio Rodriguez, who also has pushed for it. These are men,
Yes.
and they're pushing for a cause that makes a difference in the lives of women. That's a big deal.
Yeah.
And we have to do this together.
Thank you so much for joining us.
Thank you. Thanks, Anna.
We'll put some links and information if you want to get more information on our Focus Facebook page and on our website. That's Dr. Nishtha Sareen, Medical Director of the Women's Heart Program at Ascension St. Thomas. We'll put info so you can find out more about that. Thank you for listening today. Make sure you join us again next week. I'm Anna Marie, and that's Focus.